of discussion is pharmacology. So we're going to start getting into the drugs that you guys can give in the ambulance. We are going to talk, obviously, mainly about the EMT scope of practice, both National Registry and Vermont State. But you're also going to be introduced to some EMT level drugs and paramedic drugs. Okay? So, topics of discussion tonight: medication nomenclature, basically the naming system of meds, medications that EMTs can give, so what's going to be carried on your truck, what you're allowed to give in the field, assisting with prescribed medications, that's something that's part of the EMT scope, assisting patients with their meds, that is specific to particular medications, but we are going to talk about those meds that you can help with. And then general information about medications, the pharmacokinetics, the pharmacodynamics, all that stuff, how a medication actually works in the body. And then assisting with IV therapy meds, so fluids, certain IV drugs, that kind of stuff. Okey-doke. Medication nomenclature. So, your book talks very little about this, and that's the only thing I'm not happy about, so I'm going to spend much of our lecture talking about this just to make sure you guys understand the differences on how medications are named. Again, your book doesn't talk so much about that, but when it comes to National Registry and when you're tested, they may throw one term of a medication at you and you may not know that term or that name. So, let's talk about that. So, the basic component of a medication, you have the chemical name, so that is actually the physical chemical makeup of that medication. This is not something you see often. If you look on active ingredients and inactive ingredients on a medication bottle, that's what you see. The scientific name is the IUPAC name, and it's based on the molecular structure of that drug. So it's a long name, it's not commonly used, but it is that active and inactive ingredient on the back of the drug, or on the pill bottle or whatever. So, an example of this: 2-acetooxybenzoic acid, aka aspirin. That is the chemical name of aspirin. The acetylsalicylic acid is the generic name, and we will talk about generic names. But just so you understand, the chemical name is the physical chemical makeup or the molecular structure of that drug. Okay? Another example, acetaminophen or Tylenol. The chemical name of acetaminophen is N,4-hydroxyphenyl acetamide. I'm not going to quiz you on how to say all this stuff unless you take an organic chemistry class.
Yeah, I was just going to throw in, for anybody who's like freaking out right now, the chemical name is rarely used. Like, so,
you won't see that ever.
Yeah, often your generic names are the ones, so like, you know, like we carry Tylenol. Well, it's not called Tylenol on the truck, but, you know, or, well, in the pill form it is, but, so, yeah, so don't lose your mind thinking what, you know, N,4-hydroxyl, whatever that is, like, don't worry about it. It's just, this is good information for you to know.
Yeah.
You
may have a test question that gives you the name of a medication, and it may ask you, is that the chemical name, the generic name, or the brand name?
Right.
Okay? So if you see a long, drawn-out chemical formula like this, that's the chemical name. Okay? And again, any pill bottle you look at, any medication you look at, that's the active ingredient or inactive ingredient on the back of the bottle. Okay? That's chemical name. Generic name. The generic name is what we use when we're doing our narratives, when we're talking to the patient about a drug. This is the name we use. So if I'm talking to somebody about Benadryl, or I'm writing in my narrative that I gave somebody Benadryl, I'm not saying Benadryl. I'm saying diphenhydramine. Okay? So the generic name uses a chemical identifier towards a specific drug class. So that's either in the suffix or the prefix of the drug. Okay? So the beginning of the drug name or the end of the drug name. So it's most commonly used. It's the most commonly used name for medications in the medical field. So when we're talking medications that we're giving, we're using generic names. Okay? So some common generic names: acetaminophen, ibuprofen, metoprolol, furosemide, loratadine, diphenhydramine, and lorazepam. Any of these look familiar to you guys?
Yeah.
Acetaminophen's in Tylenol, ibuprofen's in Advil, metoprolol, there's a bunch of different names for that one.
Thinner.
The main, what's that?
A thinner?
Nope, it's not a blood thinner. It's actually a beta blocker. So it's for hypertension. You're not going to be quizzed on that stuff. What I do want you to take away from this, so if you look at the suffix, so the end of the drug name, this is specific to the generic name. The suffix correlates the drug class, okay? So we'll use metoprolol for an example, ending in OLOL, okay? Those are a class for beta blockers. Metoprolol, labetalol, atenolol, those are all beta blockers, okay? EMID, those are a drug class. The water pill that people say they're on, if you ever go to a patient, they say, I'm on the water pill. That's Lasix or furosemide, turosemide. Those are all specific to that drug class. Does that make sense? I'm going to list a few of these a little later on. So your more common ones, your OLOL, Prils, statins. If anybody's on a statin, that's a specific drug class for hyperlipidemia, that kind of stuff. All right, does generic name make sense to everybody? This is the most common name that you see that we use in the medical field. Then we have brand names. So these are trademark names. They're more easily identified by the public. So if you say to somebody, I gave you diphenhydramine, they're going to look at you like, what, I don't know what that means. If you tell them I gave you Benadryl, okay, that means something to me, right? So it's a trademark name. When you're listing a trademark name, the first letter is always capitalized. That is a requirement, whereas generic names, that's not necessarily true. They do not have to be capitalized. Trademark names do have to be.
Proper noun.
Yep. So, common trademark names, Tylenol, aspirin, Advil, Motrin, Benadryl, Claritin, Lipitor, Vicodin. So I am going to kind of quiz you guys on that a little bit throughout the night, just to make sure you're using the correct name with medications. So, Tylenol, what is the generic name for Tylenol?
Acetaminophen.
Acetaminophen. Aspirin, that's a tricky one.
Ibuprofen.
Nope.
Nope.
Acetylsalic acid. Okay. Advil would be ibuprofen. Motrin.
It's also ibuprofen.
Yep, it is also ibuprofen.
Question on the whole aspirin thing, because now I'm unsure if
Yep.
I've been doing this incorrectly.
Yep.
So whenever I list in my narrative, I say aspirin. I don't spell acetylsalic whatever. Like, I'm doing it right or not?
That's fine.
Okay.
That's fine. Usually with all our other drugs, we're using diphenhydramine or nitroglycerin or epinephrine, that kind of stuff.
Right. Okay.
In the case of aspirin, there aren't really that many offsets of aspirin.
Is it Bayer?
Bayer aspirin is one of them. So aspirin kind of goes both ways, whether it's used generic or brand name. It is actually considered a brand name. So yeah, that's kind of a toss-up on that one. Claritin, that's a common drug that a lot of people are on. What is the generic name for Claritin? Loratadine. If you look at, so Claritin is a brand name.
Just gonna say.
Yep. If you look at other allergy medications, one of the key things is Loratadine. It's a antihistamine. And then Lipitor, Vicodin, those are less common ones. Okay, is that clear to everybody? I just want to make sure you take that away because your book doesn't go into that very well. Just to make sure that makes sense. So when you're listing in your narrative the medication that you administered, you're listing the generic name. Okay? Alright. Medications that EMTs can administer. So I have pulled all the meds that you guys can administer up here. We're going to pass them out. I believe you take more away if you actually see, feel, look at what the drug looks like as opposed to just seeing it on the screen. So we'll pass the meds out, let you guys get a chance to look at them. So, there are 3 of these meds that I have added that are part of your Vermont State EMS scope of practice, and there is 1 medication on here that is part of your national scope of practice, but not part of your Vermont State scope of practice. I don't mean to confuse you on this, but I'll go into specifics on them. So aspirin. Aspirin is in your state and national scope of practice. Oral glucose is in your state and national scope of practice. Oxygen is both state and national. Activated charcoal, nationally in your scope of practice, not in your state scope of practice. You have to be an EMT or paramedic to give activated charcoal.
What's the rationale on that?
Vermont's ahead in some things and behind in others.
Okay.
Realistically, I mean, it's an oral medication. It's not necessarily going to save a patient's life, but it'll prevent them from getting worse. They're actually kind of pushing activated charcoal out of our protocol because they're not really seeing any big changes with it. They're kind of running into more issues. I'll talk about it a little more
I was
later.
gonna say, it's usually pretty rare that you actually end up
Ever end up
administ-
getting it.
Yeah, you get it.
So our
anyway,
criteria to actually give activated charcoal is one, it has to be taken within the hour. So whatever they tried to overdose on, let's say Tylenol for instance, it had to be within the hour. You have to have medical control's permission to give it. And then
That's usually where you get shut down
Yeah.
right there.
medical control for some reason does not like activated charcoal. The other thing with it is the patient can't be altered, so they have to be able to swallow. It tastes terrible. So the other issue you run into with that is they start to vomit, and then if they start to lose consciousness, now you're worrying about aspiration. So there's a lot of things with this that they're just saying, you know what, leave it as is, and we'll treat the other symptoms towards it. Back in the day, before they started using activated charcoal, any idea what they used to use?
Peroxide.
Stuff to make you puke.
Epicac.
Yeah.
Ipecac.
I saw it on Family Guy.
I was gonna
There
say,
you go.
Google the Family Guy episode
Google
about
Family Guy,
Ipecac.
you'll see what Ipecac does.
You'll not be disappointed.
Right, yeah, or you will. So Ipecac actually stimulates vomiting. So before activated charcoal came out, they would actually give Ipecac to try and stimulate you to vomit out everything that you just took. There's issues that run into that because now you can worry about aspiration, so their vomit gets into their lungs. More issues than you're already dealing with. So anyways, activated charcoal in your national registry, not in your state. Narcan is in your national registry and in your state. These next three, albuterol, acetaminophen, and epinephrine, are in your state scope of practice, not in your national registry. Okay? The only exception to that is epinephrine. That is in your national scope of practice as long as it's one of these guys
Yeah.
and it's the patient's. Okay? So, let's talk about each one of these. Aspirin. Yep, go ahead.
So I would assume that when we do our NREMT test, we're answering the questions as far as they want them.
Correct. You have to go per national registry
Okay.
because you're testing for national. But I want to touch on these because once you get your national registry and get out in the
Yeah.
field, you got to know what these are.
Yeah.
Yeah.
But yeah, do a big focus on what's required of national registry.
Yeah.
And we're going to hammer you guys when we do our psychomotor exam.
And the Epi one, there's an additional like ready, check, inject training you have to do like once you get certified. So yeah, it's
Yeah, we'll go over these. So there are certain medications that the state allows us to do that requires additional training. One is for EMTs, doing ready, check, inject. This is just an extracurricular training that enables you to give epinephrine without using one of these guys. So it's actually physically drawing it up.
Does that count as like our research hours too?
Oh yeah, yeah, absolutely, definitely. So yeah, that's one of them. The other one for paramedics is heparin. That's an extra training we have to go to in order to take patients on heparin down. Aside from that. So, aspirin. What's the generic name of aspirin?
Salicylic acid.
Acetylsalic acid. Good. So aspirin. Why do we give it? What is our purpose for using aspirin?
In the blood.
Kind of. You're close.
Pain reliever.
What's that?
Pain reliever?
Nope. We do
Triple aspirin's
not
usually
use it.
directly after a heart attack, or if it's a suspected heart
It's
attack.
administered to patients with chest pain and of a suspected cardiac origin.
Good reading.
Justin can be.
So, in the world outside of EMS, outside of the hospital, people take aspirin for pain relief because we have prostaglandins that stimulates inflammation. Inflammation triggers our nerves, triggers that, hey, I have pain somewhere, that just kind of increases the pain threshold. Aside from that, that's not why we're using aspirin. If somebody goes to you and says they have pain, you're not giving them aspirin for that pain. I want to make that clear. We are giving aspirin for one specific purpose, and that is for cardiac. It doesn't, I want to be careful with that. It doesn't thin your blood. There's a difference between a blood thinner and aspirin. Good. Yes. So aspirin works on your platelets. So anybody tell me what platelets do in our blood?
Clotting.
Carry on.
Serve heavy Swiss.
Nope. What's that?
Never mind.
They assist in clotting.
They assist in clotting. So
Oh, so it's an anticoagulant kind of?
not really. It's an antiplatelet aggregate. So there's a difference. Anticoagulant like warfarin or Coumadin,
Yeah.
those work on a specific portion of the clotting cascade. And that focuses more on like fibrinogen,
Yep.
that kind of stuff. Where aspirin comes in is it's an antiplatelet aggregate. So to sum it up, it basically makes our platelets really slippery. So during normal clotting, if we have a blockage, let's say in our coronary arteries,
They stick together and makes us swim it up.
they stick to the blockage and they actually build up to cause a worsening blockage or further blockage. They're kind of doing their job because if we have a cut somewhere or a lacerated artery or anything like that, those things need to stick there to try and build the clot and stop the bleed. So they're doing their job. In the presence of a heart attack, we don't want them to build up because they're going to make that clot worse and they're going to narrow that artery worse. Okay? Aspirin in the presence of heart attacks saves lives. I can 100% tell you that. We do give patients nitro, which helps, but if you're not giving them aspirin, you are not helping them. So, you'll see some patients who are on a daily 81 milligram chewable tablet. That's why. They've either had a previous MI, they have a history of angina, some form of cardiac issue. They're on a daily aspirin, and that's why. So, let me make sure I covered everything.
And understanding that difference between blood thinner, anticoagulant, and platelet anti-aggregator thing, that's important because it's that's the pharmacokinetics of the drug. So that's important to understand and know that.
Right. So aspirin, if somebody tells you I'm on a blood thinner, okay, what blood thinner are you on? I'm on aspirin. You're not on a blood thinner. You're on an antiplatelet aggregate. So it's not really thinning your blood, it's just preventing further clot buildup. If they tell you they're on warfarin or Coumadin, then yeah, you're on a blood thinner, 100%. So that's kind of the main thing with that. Just make sure I'm not missing anything on that. Aspirin dosages. So our protocol, an adult dose, is 324 milligrams of aspirin, chewable. What I will say with that, if a patient's on a daily 81 milligram tablet of aspirin and they took it that day, are we still giving them 324? No. It is a total of 324 in a day. So if they took 81, how much are we giving?
3.
Which is a total of?
243.
243 milligrams. Make sure you ask those questions. If you're going to a patient with chest pain and you didn't ask the question, hey, have you taken aspirin today? Well, now you're giving them more aspirin than they need.
Is it always chewable or is there other orals? You always just
I've
carry
only
chewable?
known of chewable.
Chewable.
I've never seen it in any other way. I don't know if you
What's
have.
the strength of aspirin that you buy in the drugstore for a headache?
Okay. So there's adult dose aspirin, which is 324 milligrams in one tablet.
Okay.
And then there's baby aspirin, which is 81 milligrams in one tablet.
So we're given the same, well, actually, aspirin, when you take 2, if you had a headache.
Don't exceed 324. That's the only thing. Huh?
No, but I'm saying, not
Like cardiac
EMS.
aside.
Somebody
EMS
goes
for
into
the-
the drugstore and buys aspirin, don't they normally take 2 pills for a
I'm
headache?
assuming it's the 2 of the baby aspirin. I don't know if it's the adult dose.
Okay.
So the thing about aspirin, aspirin's half-life is 7 days. So aspirin circulates and lives in your system for 7 days before its concentration and potency is less than half from its original. So that's why we don't want to give somebody too much aspirin because that's staying with them. in their body, and it takes a while to break down in their body. So when somebody says adult aspirin, and that's a good thing to specify with them, how much aspirin are you on? Be specific. Are you on 324 a day, or are you on 81 a day? Okay?
And adult aspirin is 325.
So,
Yeah, they say
I know it can
drug companies. So
and it's 250.
most drug companies are 324, some are 325.
Okay.
It's just like acetaminophen. Some come in 650, some come in 500s, some come in 250s. But most commonly is 324. So the one we carry
81.
is the 81, so we carry the baby aspirin. You guys can pass this around. So that's what we carry to give to patients. 4 tablets, chew them up, they taste terrible. They always ask for a drink afterwards. But that's the drug.
So that's part of the reason we're doing the baby aspirin, because oftentimes, depending on like severity of symptoms and stuff, for anesthesia purposes, you know, the patient, that's why we ask, like, how long ago did you eat or drink anything? So if you give them a tablet, like, can I have some water, and they chug a bottle of water, that may create complications down the road. It doesn't really do much for us, but down the road, when it's like, oh yeah, give them a bottle of water, it's like, okay, great. And that's something that the doctors would need to be aware of down the road. But so we give them this. It tastes like a weird orange flavor, and it's good enough. So
Yeah, it's very chalky,
yeah.
especially if the patient's already got a dry mouth. That just makes it 10 times worse.
Yeah.
Sometimes we carry lemon swabs, which help. It's just like a lemony lollipop, basically. And it just helps to kind of moisten the mouth a little bit. Any questions on aspirin? Everybody good with that? So that's one of your drugs you can give. Oral glucose. I'll pass that around. So oral glucose, what is it? What are we using it for? Are we using it for hyper or hypoglycemia? Hypoglycemia. So ironically, we actually have the same one. So it's 15 grams of glucose. It comes in a liquid form, a liquid bottle. Kind of cool. State of Vermont is the only state that actually constitutes using maple syrup in place of regular everyday
It's
syrup.
written in the protocol.
It is actually in our protocols to give maple syrup. Go Vermont. So, we actually used to carry maple syrup. We haven't carried it in a little bit, but yeah, it's kind of cool.
Everyone was
Tastes
like,
better.
I got low blood sugar.
Right? Exactly. I put that on my pancakes. So, we're using it in the presence of hypoglycemia. So we're looking for common signs and symptoms, known prior history with diabetes.
And I just wanted to add on to that, it specifies pure Vermont maple
Pure
syrup.
Vermont.
So
100%
if
Vermont
you
maple
use
syrup.
Maine maple syrup, you're in violation of the protocol.
Yep.
I thought I was joking when I said Agency of Ag worked hard on that policy.
Oh, I'm
it comes
sure
up
they
every
did.
couple of years.
So it is actually in there. So yeah, the big thing about oral glucose, number one, the patient needs to be awake. They need to have a patent airway, and they need to be able to swallow. You're not just opening their mouth, they're unconscious, and pouring maple syrup down their mouth. For the love of God, don't do that.
Seen it done, don't do that.
Yeah.
Or
So,
you throw a waffle in there with it.
yeah,
That's gonna.
fix their sugar, but now they can't breathe. I don't know.
Waffle sticks.
So, making sure, and this is going to be a classic NREMT question, patient's unresponsive, they have a sugar of 45, and one of their questions may be, what are you doing for treatments? If you say administering oral glucose, that's an automatic fail. You cannot give oral glucose to a patient who's altered mental status, unconscious, doesn't have a patent airway, and can't swallow. Okay? So that's the big thing about that.
What do you do in that case? Like, what would you give them to get?
Call for ALS, and then we'll give it either through glucagon, which is somewhere in here.
Is it in the stat pack? Do you get it?
Yep. So, we have a few tricks up our sleeve.
Hypoglycemia is pretty cool because, well, not for them, but it's cool for us because it's one of the things at the ALS level you can
Yeah.
essentially fix in the field.
Literally, they're
Like
like
you're-
completely comatose,
Yeah.
not awake, family's freaking out, and it's like,
Give me a sec.
Yeah, exactly. It is like very
Yeah.
like, you know, put on the aviators, be like, hey, need anything else?
Right? Now you're good.
I had a resident where I worked last as an LNA, and she was prone to that. And it was either maple syrup
Just so you
or
guys can see it, this is.
and you could tell when she was going into very low blood sugar, even before you took her sugar, just for how she was.
Oh yeah. Yeah, and it's like, and diabetes is a weird one because like some patients will be awake and talking to you at like 25. Other people will be completely unresponsive at 50. So it all depends, you know, how long they've been a diabetic, how well they've maintained or poorly they've managed their diabetes. So like we used to have a guy in the city, we went to him almost every day, and he would still, like, he would be awake and combative when the glucometer read low. The glucometer read, it reads down to like 15 or something like that, or 20.
Yeah, it's glucometer dependent. Some will go to 30, some will actually go to 15.
Yeah, so I don't know what ours did. Ours did like 20 or something, so it would just read low. So like lower than 20, and he'd be on the couch like, ah! So you'd have to pin him down, and yeah, like, and then as soon as like you gave him D50, and he'd be like, oh,
What happened?
hey, yeah, thanks, sorry guys, yeah, did it again, blah, blah, blah. Like,
That's
just
how
like
she-
nothing happened. It was like, sorry.
That's how she was too.
Yep.
It's crazy.
So, what I passed around, so you guys have seen oral glucose. That's in your scope of practice to give to hypoglycemic patients. The other drugs that you're seeing, so these are what we can give at the AEMT level and the paramedic level. So, in the event they're altered, or they don't have patent airway, or they can't swallow, these are the drugs we're giving. So, D50 and dextrose 10%. Both of them contain the same concentration of dextrose, 25 grams. The only difference between the two is how much they're diluted. So dextrose, 50%. What do we think that means?
It's diluted 50%.
50%. So for every 25 grams of dextrose, it's in 25 mLs of saline. I'm sorry, 50 mLs of saline. Okay? Half concentration. Dextrose, 10%. Is it going to be more diluted or less diluted? More diluted. So it's 25 grams of dextrose and 250 mLs of saline. Okay? I like dextrose 10% better than D50. The reason I say that, if you're using D50, you really need to make sure you have a patent line, that you're in the vein, it's going through their circulatory system, and it's not infiltrated into their tissue. Good example of this, another department, not from around here, gave D50 in a non-patent line. All of that sugar ended up in that patient's extremity, and they developed necrosis in that extremity.
What is necrosis?
Dead tissue. They'll die.
Their arm will like rot off and get it to you too.
Because you're literally putting straight sugar water in there. Bacteria love sugar. So it kills them. And tissue does not like that much sugar at once. So, when you guys go for your AEMT paramedic scope, whichever you choose, this is one of the drugs that you're going to learn. And you may end up assisting, even with the EMT scope, assisting in setting this stuff up. So, any questions on glucose? Should have covered everything there. So yeah, it comes in usually 15 gram doses. When you're doing your documentation, you say we gave 15 grams of oral glucose. Okay?
So medic isn't going to do anything more than AEMT
For that type of stuff, nope. The same thing, AEMT is in the same scope for medic and that. They can give glucagon, they can give D50, D10, and you may not even have to give any of that. Just simple oral glucose can help. Oxygen. Is oxygen a medication?
Yes.
Absolutely. So it is actually the most common medication we give at any scope, at any practice level. It's very simple to give. Things about oxygen. We can give it in multiple ways. So one way is using a simple nasal cannula, like this patient's getting in the picture. Another way is through an NRB. This is actually a nebulizer mask, but basically the same thing. An NRB. Yep, non-rebreather mask. Other forms, CPAP, if anybody's ever seen CPAP or BiPAP. And then intubation. So those are the most common ways we give oxygen. Why would we give oxygen?
Help them breathe.
Low oxygen
Low
level.
oxygen.
Low oxygen, exactly. So hypoxia. Most patients we go to see, I would say 50% of them require oxygen, or require some form of supplemental oxygen. One of the most common things we do that helps alleviate anything, some fluid and some oxygen. Those are the two quick things we can do that really helps alleviate patients' symptoms. One thing I will say about oxygen, is there anything bad about it? Can it hurt anybody?
You can give too much.
Yeah.
What about it?
You can give too much. So,
How? What does that mean?
For instance, head injuries, too much O2. I forget what the reasoning is behind it, but that was one of them.
Okay, you're on the right track. What about oxygen can be bad? Anybody know?
Does it make the
You
blood,
don't need it.
make the blood do something?
You don't need it.
Yeah.
So, there's two components of oxygen. Number one, oxygen can actually act as a vasoconstrictor. Not as significant as certain drugs would give, but it actually does play that part where it can function as a vasoconstrictor. Another thing, free radicals. Anybody ever heard of free radicals? They say blueberries are an antioxidant which prevents free radicals. Certain antioxidants will help prevent them. Basically, what a free radical is, in general terms, O2 is an unstable compound. Okay, it's got extra virulence electrons that circulate around the outside and are looking to bond with other molecules. Okay, so O2 is unstable and it wants to split and pair with other compounds. When it does that, it actually causes other atoms to become unstable, and that can denature our DNA. Okay, that's more of a case where somebody is prolonged on O2, high levels of O2 for a while, not necessarily what we're going to do in the field. Where we're more concerned about giving too much oxygen is more focused on COPD patients. Why COPD patients?
If their lungs aren't expanding the way they're supposed to start, so if it's a vasoconstrictor, it would prevent them from.
Maybe. Not what I'm looking for. But close. I see where you're going with that. So, your textbook, go ahead.
Because they're COPD, they're not oxygenating their blood well enough, so you're constricting their blood flow more.
I dislike it.
It actually has
No, I
nothing to
didn't.
do with constricting.
I want you to think about respiratory drive. What stimulates us to breathe?
Oh, yeah.
We're not sitting here thinking
You're
about-
upsetting the balance of the CO2, O2 balance.
So what chemical is stimulating us to breathe right now? We're not thinking about breathing. So what's telling our body, hey, take a breath?
Carbon monoxide.
Not carbon monoxide,
Rare.
carbon dioxide. And some people get that confused. They think, oh, I need more oxygen to help me breathe. Our body has receptors that are focused on CO2 concentrations in our blood. Okay? COPDers, because of the basically detriment to their lungs, their lung capacity, the surfactant around their alveoli kind of deteriorates. So they change from relying on CO2 to stimulate the respiratory drive to oxygen concentration to stimulate the respiratory drive. Okay? So if I flood a COPDer with a ton of oxygen, their body's taking that in and saying, oh, you have plenty of oxygen, slow down the respiratory rate. That's not going to help them. You can actually see them start to develop altered mental status, decrease respirations, and kind of deteriorate on you. And that's just simply from giving too much O2. Okay?
I remember vaguely back, a little older than everybody here, but there was a period when there was an issue with like newborns.
Yeah.
Because they were like a week or 2 weeks early or whatever, they would put them in the incubator, and then obviously next thing you know they were blind.
Yep. Yeah, our protocols have changed a little bit with kids. So when EMS first started, it didn't matter what you called for. High flow O2. Everybody got it. Didn't matter if you were an infant, didn't matter if you were 100 years old. Everybody got high flow O2. That's changed. We're not giving oxygen to everybody. And that includes kids. Don't just give a drug just because my book says I have to give it. What are you looking to achieve with that drug? Have a purpose to it. If you go to a child and their oxygen levels are 70%, yeah, they probably need oxygen, right? Their oxygen concentration levels are low, and that's going to support them. But if their oxygen saturations are 99%, there's no reason to give them additional oxygen, right? It does play an effect long-term with development, high concentrations of O2. From what I understand, our little interventions don't have an effect on
Yeah,
kids as
so
much.
when you're dealing with patients that are like COPDers, and their, you know, if their O2 saturation is 82% and you give them oxygen and you bring them up to 95%, even though their normal range is like 88 to 92, that short, you know, even coming from Richford, if you know, that short half hour, 45-minute ride at 95% is not going to be, it's not going to switch them over to, it's not going to shut down that hypoxic, the hypoxic drive. It's, you're fine at those levels for a short time. These are levels like, if they were days at 95%, that's when you're going to see that deterioration. There's a very low likelihood of us ever seeing that with our stuff, but it's still something.
They could do it to themselves.
They could do it to themselves,
Yeah.
absolutely. Yeah.
So, just to clarify that a little bit with COPDers, the reason they transferred from being CO2 dependent with respiratory drive to O2 dependent is because of the change in their lung capacity. They become chronically hypercarbia, okay? So that means their CO2 levels in their bloodstream becomes chronically high. And that's abnormal for them to have chronically high CO2 levels in their bloodstream. And because of that, their respiratory drive and the chemical compound, the receptor sites change to, okay, I'm looking for O2 concentration to take over my respiratory drive. Does that make more sense? With how that
Almost in the
works?
same terms as asthma.
Mhm.
COPD is not the same, I know not totally the
Right.
same, but it's almost the symptoms.
Symptoms can be similar.
You're
COPD
fighting to
exacerbation.
breathe. You're fighting
Right.
to breathe, because
Yeah.
you've got all this other stuff going on.
Absolutely, in the field they can present the same. But typically, you'll know somebody has a history of COPD. They'll say, oh, I have a history of COPD. I'm chronically on 2 liters of O2.
And long-term use of O2 is not going to affect an asthmatic.
Right. Yeah. Yeah, asthmatics usually aren't on O2 at all.
For those that are interested, the normal drive you breathe off from is called the carboxic drive. And the backup one, the one that COPDers use, is called the hypoxic drive. Which is hypoxic is going to come up more and more as we talk about respiratory, but just for your information, if you guys are curious, so it's the carboxic drive is what we breathe off of normally. That's what all of us are using tonight.
Right.
This comes up in another chapter.
Yes.
Yes.
When we get into pathophysiology and
Yeah.
the respiratory emergencies. The other thing I'll say about oxygen. What is the normal concentration of oxygen in the air that we're breathing right
Like
now?
21%?
20 to 21%.
How much do you exhale?
That's that.
Just curious if anyone knows.
That's a good question.
About 15%. You exhale about 15% of oxygen. So your body only uses about 6%.
So, the higher in altitude you go, is the oxygen concentration greater or less?
Less.
Less.
That's why you get drunk faster at high altitudes.
This is true. So, high altitude sickness, that type of stuff, that's due to hypoxic development from low concentration of O2 in the atmosphere. So, when I give somebody, let's say we put them on an NRB, what concentration of oxygen am I giving them when I put them on an NRB?
For COPD or for something?
Just in general, I put an NRB on any patient.
High flow of 15
Sure.
liters.
15 liters a minute.
Yep. On average for like traumas, what I was topic.
Right.
You can reduce that for non-traumatic.
Mhm.
Again, so
What's my concentration of oxygen I'm giving them?
out of an NRB, 80%.
Nope.
No.
100%.
Uh-oh.
100% O2.
Okay.
So, and you'll see terms like FiO2. That's, I'm gonna watch this, fraction index of oxygen.
I'm sorry I missed that. My wife's
FiO2.
delivering food. Yes.
Fraction index
I
for
believe
oxygen
so.
concentration, okay? So, normal FiO2 in the air is 20%. When we put somebody on an NRB, FiO2 is 100%. Okay?
That's the same thing with the nose
Nasal
thing,
cannula is
because it's still
less.
the same.
You're giving them 100% of oxygen in their nose,
But they're still breathing.
normal ambient air. So FiO2 for nasal cannulas is usually around 45 to 50%, because you're also accounting for normal air they're breathing in. And a nasal cannula is a good starting point for patients. It doesn't necessarily mean you just have to slap an NRB on them first go. You can say, hey, let's try a nasal cannula. If that's not working, let's try something else.
Yeah, the way the protocol is written is like oxygen is like titrate to effect.
Yeah.
So, like you put them on oxygen, their SpO2 improves, they become less symptomatic, you can dial back your treatment a little bit. But yeah, back when I started, it was 15 liters high flow O2 NRB for a stub toe to a gunshot wound. Like it was just everything. So we don't have to do that anymore.
Titrate to effect, you're going to hear that a lot. That's oxygen. Any questions with oxygen? We covered everything up. The only other thing I'll add to that, when you're documenting the amount of oxygen you give it in liters per minute. Okay? So I actually have an O2 tank here. So you see the gauge on the side with the numbers. When you dial it, that's your number in liters per minute. Okay? So when you're writing how much oxygen you give somebody, if I dial it to 2, it's 2 liters per minute. Okay? And that's just the amount of flow coming out of the O2 tank. Oh, National Registry loves to fail you on this. There is a station where you actually have to set up an O2 tank. We'll work with you guys on it. A quick fail for that station is if you leave a standing O2 bottle alone.
Yeah.
An O2 bottle standing, your hand has to be on it.
Or in the rack.
Or laying sideways down on the floor. The floor is even fine. But it can't be standing.
Yeah.
Okay?
It has to be laying on its side. Like,
That is a quick and easy fail for them.
yeah, because you ever seen Gone in 60 Seconds? Like, it's a pressurized cylinder, so if you do knock the head off, it becomes a torpedo.
Yeah.
So what was you said the percentage for the mask and the nasal, but what is it for like intubation or whatever?
100%.
Is it?
Yep. Because our intubation, we have the tube, which is we're breathing for them through the BBM mask, and the BBM mask is connected to the O2 tank, which is 100%. In the hospital, you see, if you look on the walls, you'll see 2 valves. One's oxygen, one's air. So air is just normal ambient air, and then oxygen is specifically concentrated oxygen.
When they set them up on a vent, though, they can adjust
Yeah.
the FiO2.
A ventilator.
So if you get in, you start doing like critical care transports with the RT or whatever, like you can ask the RT like, well, how much oxygen? He'll tell you what the percentage is and everything's got it set at. So
Then you can adjust it, yeah. All right, that's everything on oxygen. Activated charcoal. So this is a drug you need to learn. It's not in your Vermont EMS scope of practice, but it is in your state scope of practice. So activated charcoal. Activated charcoal is the generic name. Actidose is actually the brand name. Okay. So our purpose of using activated charcoal is for patients who any type of poisoning or medication overdose. Okay. This is literally, if you burn a fire and the charcoal left over in the fire, this is literally what that is. Okay. Basically, it's just a large compound of carbon. Carbon is a neutral atom, and it bonds easily with other substances and neutralizes that substance. That's the purpose of this. Somebody takes a bunch of Tylenol, we give them activated charcoal. The activated charcoal prevents the body from breaking down and absorbing the medication. So whatever they've absorbed and broken down at that point, we can't fix that. But what we can do is prevent them from breaking down anymore. Okay? So it comes in liquid form. I've actually got it right here. Before you give it to somebody, so the charcoal actually kind of solidifies down at the bottom, so you got to make sure you shake it up really well. And then you break off the top and just have them drink it.
How much?
Wasn't.
The whole thing.
Oh boy.
Yep. The whole thing.
Now you can't assist them with drinking this, right?
No. They have to be able to drink it on their own and willing. Most of the time they're not willing.
Yeah.
yeah, they usually kind of like take the first chug and like they're like.
We have some that shoot it like a shot. It's impressive.
4 ounces.
Yeah, there was one girl in the ED down at UVM, I saw her like chug the whole thing, like it was impressive.
Yeah. So,
Back in the day, we used to have some of these military members that were off restriction that were really bad alcoholics. So we'd have to like give them antabutes.
Yep.
And then you go out a couple hours later and they'd be around the corner throwing up because you took a couple shots. Once you got it done with their system, you're off to the races again.
Yep.
Back at it. They were back right at it again. It's terrible.
Right. So activated charcoal is not the end-all, be-all. Obviously, we can't just give somebody activated charcoal and say, all right, fix the problem, we're good now, you can go home. You got to transport them to the hospital. There are certain things that we cannot give activated charcoal for. So we can only give it for non-caustic substances. What does that mean? Caustic versus non-caustic.
I think of caustic like corrosive, so it's
Corrosive.
just aggressive.
Yep, exactly. So basically any chemical component that comes into contact with tissue and degrades or kills that tissue.
So if a kid swallows a cup of gas, you can't give him that.
Gas, some other
Clorox.
common ones we see, Clorox,
Bleach.
bleach,
But you just start
antifreeze.
flooding them with water. Try to get them to drink as much.
Nope, you don't want to put more into their
Pump
system.
them.
They'd have to go to the ER and then they would have to have their stomach pumped. Yeah,
Diesel therapy for us.
yeah. Not a lot we can do for that, unfortunately.
I had a guy try to kill himself with he mixed it up in a pint glass. He had ice, Clorox, bleach, Easy Off oven cleaner, and he was like, here we go. And he took like one sip of it and started throwing up. But he was like, he mixed a nice drink for himself.
Yeah, quite the cocktail.
That's a crime.
That stuff there says 15 grams, and here you got 25. Does it matter? Just
Now, so we
size of
carry
person?
25 grams.
Okay.
You're allotted up to 50. I'll have to double check on that.
Yeah, I'm looking for protocol right now.
The other thing with that is you have to call med control before we can give it. And it's always a good idea to double check with poison control. So just call them, they're great. They'll tell you, hey, these are the signs and symptoms to look out for. If they took this amount, go ahead and give activated charcoal. They're a great resource. There are so many drugs out there, so many chemicals. We're not going to memorize them all on can I give activated charcoal for this or not. So they're a great resource for you.
25 to 50.
Okay.
One of the car ones, the guy ate a whole bunch of Bondo.
It's
Oh.
a sandwich.
Oh, gnarly.
Is the logic for not doing it for caustic, is it might make them throw up, or is there a different?
Two things. Yeah, if you make them throw up. Second thing, it won't do anything. It won't make them better.
It's
It won't
probably
make
the
them
big
worse.
thing, yeah.
It won't do anything for it.
It might make it worse if they're throwing up the caustic substance.
Yeah, yeah, then you get GI tract burns.
Burn on the way up and down.
Yeah, yeah, those are messy calls. Those are ones you do not want to go to. We go to them often enough. Anyways, activated charcoal. Sure I'm not forgetting anything on that.
National only.
What's that?
National only.
National only, not state. Naloxone. Is naloxone a generic name or brand name?
That's generic.
Generic.
Narcan is the brand name.
Yep, exactly.
Pay attention to this one.
Pay attention to this one, because I can guarantee you will give it at some point in your career.
was just saying that the other day.
Yep.
Where's it almost gone?
Yeah, you will
Put it in
you will become
perspective.
familiar with this medication.
Since January 1st of 2021, I've had 9 overdoses this year.
Oh, shit.
We get 3 in like, what, 2-3 weeks?
Yeah, pretty much.
They don't just,
They're like back to back, they're just
it's
coming
not
in
just
there.
for like junkies, like if you say you get your wisdom teeth out and you're prescribed a narcotic, they give it.
Absolutely.
case.
Yep.
Oh yeah, same thing happens in the nursing home. The
Uh-huh.
fentanyl patches, medication patches, it's like, oh, time to change it out. Oh, it doesn't look like they have one. They put on another one, put on another one. Next thing you know, patient's wallpapered with
You go to
fentanyl
that
patches and
often
they're
enough.
out cold. So
Yes.
it's not,
It's not
so
on
yeah,
purpose,
it's not just
but
for,
incidental overdoses.
like, yeah,
It
it's not
happens
just for
at nursing
junkies, it's for anybody.
Yeah. So Narcan. It's an antidote for a patient who is unconscious and in respiratory failure after taking a narcotic. It does not work if the patient has not had a narcotic, obviously. So the main focus of Narcan, it displaces the opioid on the opioid receptor sites. Okay? So it actually has a higher affinity than some opioids. For the opioid receptor site than most opioids, like heroin. However, carfentanil, anybody ever heard of that? More common down south. That has a higher affinity for the opioid receptor site than Narcan does.
So it doesn't work very well.
Doesn't work very well at all. It takes a lot of Narcan to revive those patients.
So the second line there, that's an important point to when you're arguing with your patient about them not taking anything when they're trying to tell you that. So yeah, that's important. Just because, like, until recently, I had a gentleman broke the streak, but every one of my overdose patients denied taking anything. They'd be completely out. You give them Narcan, they wake up, and I didn't take anything. It's like, dude, this only works if you took a specific class of drug. Well, I didn't. No, nothing. Like, okay, right.
I think our last one was like that, Thomas.
They
usually all
I think
are.
he was.
If they haven't taken a narcotic and they're unresponsive,
It's not going to do anything.
it's not gonna, so like, there's no reason to not give it. That's what it is,
Usually.
usually.
There is one side effect to Narcan. So it can actually result in edema buildup in your lungs. It's not very common, it's rare, but it can happen. So it used to be old EMS, cardiac arrest. You would have your common drugs you would give right off the bat. 2 Epis, a bicarb, and Narcan. Just give it right off the bat. We're not doing that anymore. We're using Narcan for its specific purposes, so if I really suspect that somebody's overdosed on a drug, then yeah, I'm giving it. But if I have no signs or symptoms correlating with it, I'm not just going to give it to them.
Usually get pretty pissed off people too when they wake up.
Oh yeah. Some come out really combative, and some are cool with it.
Some are cool.
Yeah. So what are your common signs and symptoms you're looking for an overdose?
Drowsiness,
Unresponsive.
Unresponsive, altered mental status, drowsy.
Low breathing level.
So bradypnea, another big one. Pinpoint pupils.
yes.
That is the big one.
We
You will
call
see
it
that in
Signs
every
of drug
case.
use.
We call it the opioid triad.
Yep.
The pinpoint pupils, altered mental status, and decreased respiratory drive.
Yeah.
So you have those 3 things, you can suspect narcotic overdose.
That is a good reason to give Narcan. Okay. So really look for those big things. Some things can present like an opioid overdose and it's not, and an opioid overdose can present like some things and it's not.
Yeah.
An example, hypoglycemia, stroke, other substance abuses, not even just opioids. That kind of stuff can present like an opioid overdose or vice versa. Okay, so really use your knowledge, use what you're seeing on scene, use your patient history, that kind of stuff. Okay?
Remember that one we had where we gave like 8 milligrams?
Yeah.
And it was like after the 8th milligram, still nothing happened. And there was this like moment of pause on scene where all like,
This should work.
huh. Like, it's like, well, I'll go get the stretcher. And then he woke up. But it was like, after 8 milligrams, we're like, all right, well, I guess we're out of tricks. Like, let's go. Like,
That's how I.
That was our last one. It seems like nowadays
They
it's
gave all
taking
they could
even
get.
more Narcan.
Probably people
it
are
was
going.
dead.
8 milligrams, what was
Yeah.
that dosage on that?
That was
Two?
1 milligram on that.
2 milligrams.
Two?
2 milligrams.
Two milligrams.
So do you
So
guys
how
have?
are those?
Yep. So these are 2 milligrams and 2 mLs. The ones that the police are carrying. Anybody know what those are? 4 milligrams.
4 milligrams, same
So
ones up in
those
prison.
yeah.
are just like these. Okay. So those are auto injectors.
Let me go grab one.
Yeah. We're actually doing Narcan leave behind kids too.
Yeah.
Something in Vermont. I think they're doing it elsewhere.
Yeah.
Well, that's one of the last things you get
Is that
when
one of
you
the
get out of
practice
jail.
ones?
You want Narcan?
Yeah.
Got one of those on that.
At St. Mike's, we had like the nasal ones.
Yep.
You need to push up.
Yep. So that's what these are. So ours we carry the 2 milligrams and 2 mLs, and you use. I had a nasal
Nebulizer?
What to do with it? Right here. Okay.
Yeah, these are the kind right here that we had.
Yeah.
Yep. So those are the
That's what we
bullets.
got
Those are what the
Yeah.
police are carrying, and that's what we're giving out to the public.
Right.
So the ones we're using, this is a nasal atomizer. So it actually screws to the end of the syringe, and you're just injecting it. So I typically do 1 milligram per nostril. Yeah, it doesn't really make a difference if you do either. It is much more effective, in my opinion, to give IV. So when I'm giving somebody IV Narcan, I'm not giving them all the Narcan. I'm doing 0.5 increments. because it works a lot faster, a lot stronger, and it takes a lot less. If you're doing intranasal, then yeah, you can give all of it. But that's another one of those drugs, titrate to effect, okay? If your patient develops a respiratory drive on their own and they start waking up, it doesn't mean you need to give them more. Just give them time to catch up, okay?
What's the protocol for max dose? Because you said 8 milligrams you gave on the call. Is that max dose?
Up to 12, and then you have complement control.
Okay.
We didn't give 8, we gave them 5, figured out. It was 5 milligrams.
Okay.
You said max is 12?
I gotta double check on that. No, max dose is 8, then you call for med control.
Okay.
That case we gave 5 milligrams. It was 4 intranasal and then 1 IV. And the IV is what really turned the difference. So do your initials with your intranasal and then call for ALS, because in my opinion the IV works a lot better and a lot faster. Okie doke. Any other questions on Narcan? Get to know that drug because you're definitely going to use it at some point in your career. I can promise you that.
You gotta monitor these people because it could still
Yes.
come back.
Yeah, all right,
down the
great
road.
point. Yep, I forgot that. A lot of times when we revive an opioid overdose patient, they may deny that they ever took the opioid, or they maybe admit to it. Most cases that I've dealt with, they don't want to go to the hospital afterwards. They say, I'm fine now, I feel good, I don't feel like I need to go to the hospital. We stress to them that you need to go to the hospital.
Starting over here. So this is one of our Narcan leave behind kits. Did you talk about that reasoning behind that and whatnot?
A little bit.
Okay. Yeah, so in our protocol now, if we go to an opioid overdose and we give Narcan, the patient wakes up, at that point they're alert and oriented, they can answer all the questions. Well, they have the right to refuse medical treatment, so the state of Vermont has put out, if you suspect that that's what it was, you fix the problem, you leave more Narcan in case they go back out.
Right.
So,
And this is incorporated in our documentation.
yes.
You need to make sure if a patient refuses to be transported, we've stressed everything that, hey, Narcan only lasts for 15 minutes, okay? That doesn't mean they're gonna go back under. It really depends on what they took and how much they took. But if they're saying, hey, I don't wanna go to the hospital, we're stressing to them that you could go back out again and somebody might not be here to call 911. They have the right to refuse as long as they're maintaining mental capacity, they're able to make decisions for themselves. But if they do refuse, we need to at least offer this to them.
Yeah.
Okay?
So, and that's,
If you don't, you need to explain why.
there's not very good quality control in the whole world, like underworld of drug manufacturing. So, so somebody takes, generally draws up just a little bit in their syringe, they do it, that gets them high, that's great. Next time they do it on a different batch, that kills them, because, it's just kind of what it's cut with and the concentration and whatnot, so.
And I was right the first time. 12 milligrams is maximum dose. That incorporates you guys. You can give up to 12. That's a lot of
I just have a
Narcan.
quick question. If, for example, say a cop is chasing someone who's high off drugs, passes out, you guys get called, administer Narcan, but he denies he used anything, but you guys, apply that to him and he wakes up. Can a police officer use that against him? I guess the question is, if he says he didn't use narcotics, but then you guys applied that and he did, that's what I'm getting at.
He has to use another avenue of probable cause. He can't use a HIPAA from what you gave.
Yeah, so the other thing is the police won't charge him because you have to be in possession of drugs. So just because he's high on the drugs, and if he doesn't have any anymore, well, no problem. It's interesting how that works.
Gotcha.
But, yeah. So, but if he, arrests him for something or detains him, searches and
His paraphernalia.
finds drugs, then he gets charged with possession. But if he's just high, no problem.
Gotcha.
So if this is binding to the brain receptors, so it's, for 15 minutes, it's stopping all effects of that drug. Like he's not high, he's nothing, correct? Okay.
Yep. And then there's that risk because by that time, usually it's that 15-minute mark, the Narcan that we've administered has been used up on the receptor sites, and there's no more Narcan left available. So then if there's still any opioids circulating in their system, that's now going to bond to the opioid
How long does that
receptor
usually stay in their system?
sites. Narcan,
No, the opiates.
it depends what they took.
Okay.
Depends on what they took and how much, but
Yeah.
breaking away from the illicit drug user scenario, cancer patients, hospice patients,
Yep.
take so I'll use a personal example. My mom died of cancer. She was on a crap ton of morphine prior to her death. So my mom was an alcoholic for a very long time. She had an excellent tolerance for pretty much everything. So no problem. But if she took, what they were recommending and she went out, here's this weird consideration because it eliminates the effects of the opioid. So if you gave her Narcan, no problem, she'd come out of it. Then she would be in horrific pain.
Yep.
So it's withdrawal and horrific pain from her disease process. So it's something to keep in mind. It's
That's why we titrate to effect.
titrate to effect because you give her, if you were to give her a little bit so she starts breathing more on her own, but she's still out, that's way better than just waking her up. So something to keep in mind like that. So
Yep.
that also, if you titrate to, it's like they say, we like our babies crying and our adults unresponsive, because you wake up your illicit drug user, they have the potential to go into withdrawals, become violent, refuse transport, yada yada yada. If you improve their respiratory drive, but they're still out, we're fixing the problem, and we can transport them and not get beat up and whatnot, and all well and good. So, same.
Yep. You ever take care of a withdrawing patient, you'll know. Trust me.
Wait for that last push when you're backing into the hospital.
So as long as their respiratory drive is good, their oxygen levels are great, that's what we're concerned about. I like to at least wake them up a little bit to get some kind of history as to what happened and that kind of stuff, but you'll figure out really quick if they're going to come out fighting or if they're going to be calm and cool with you.
Medical control would have given you more advice on something with a cancer patient.
Something like that. That's one I would definitely consult med direction because that's a complicated thing, because it's like we have an acute problem, they have a chronic problem, so
Yes.
yeah, so
Tricky situation.
tricky.
All right, that's Narcan. Albuterol. In your MDI administration is in your national scope of practice. However, thank you, Vermont. Vermont has opened up nebulized albuterol for you. Okay, so this is now in the EMT scope of practice. So albuterol. Typically, patients who have albuterol at home, it's administered through a meter dose inhaler, MDI. Anybody who's ever seen a rescue inhaler, that's what an MDI is, meter dose inhaler. It can also be administered through a nebulizer treatment. So I will pass these around. This is what we give to patients. One is albuterol and one is a duoneb. So a duoneb is albuterol with ipratropium bromide, which is basically for patients with pneumonia, a really wet sounding airway. We give that. It just dries up secretions, that kind of stuff. So,
Is there a reason that a patient would routinely be prescribed both and told to
Both.
do?
Yeah, so albuterol is typically prescribed to those with severe asthmaticus. Albuterol works great for that. They don't really need that ipratropium bromide component. However, if they chronically have pneumonia or COPD, then they might get dual nebs as a
I took
supplement.
care of a lady and she was on both multiple times a day.
Yeah. Yeah, one just contains that extra component to dry up airway secretions. But they do the same thing, exact same thing. So albuterol works on our beta-2 receptor sites. So when you're thinking of receptor sites, we're going to go more into it in anatomy and physiology. One heart, two lungs. Beta-1 receptors focus on our heart. Beta-2 receptor sites, two lungs, focus on our lungs. Okay? One heart, two lungs. So albuterol triggers our beta-2 receptor sites to stimulate smooth muscle relaxation. So we have smooth muscle around our bronchioles, both primary and secondary branches, all the way through. During an asthmatic attack, our bronchioles become constricted. Our smooth muscle clamps down and it really narrows their airway. So we give albuterol to relax that smooth muscle and open up their airway. Anybody ever heard somebody wheeze or have an asthma attack or anything like that? You'll know it, because they're really struggling to breathe and you can hear that classic wheezing sound. That's where this comes in. We can help them out with that. Side effects to it, it increases heart rate, it can increase anxiety a little bit, it may make them feel a little jittery. When you administer it, so per your protocol, you can give 2 to 5 puffs with the MDI, making sure when they do their puffs that they take a good breath in and hold it. Okay, sometimes they come with a spacer. If they have a spacer, let them use it. But make sure they do that good inhale and they hold it for a second. Okay? If you're giving it through this way, then it's a little solution that you open up, you pour it into that little cup, and then you hook it to your oxygen tank, and you set it at 6 to 8 liters per minute. And you'll see the mist come through. And you want them to take some good deep breaths with that.
I find 8 works the best.
I use 6.
8's better. More is better.
Yeah, whatever.
That's only the maple syrup.
Yeah, that's right. All right, so you can give it up to every 5 minutes, up to 3 doses before you call med control. Anything else with that? Any questions with albuterol?
So, let's say up to 3 doses, but you're away from the inhaler now, right? So you said 2 to 5 puffs.
Yep, 2 to 5 puffs.
Is that a 1 dose? Or are we talking
No.
about something totally different?
So 3 doses is more for this stuff right here.
Okay, all right.
They can do 2 to 5 puffs up to every 5 minutes. 3 times up to every 5 minutes.
Okay,
Okay, does that make more sense?
yes.
With this stuff, you can do 1 bullet every 5 minutes up to 3 doses.
Okay.
And then you have to call med control for additional dosing.
The heart rate component of albuterol is pretty insubstantial.
Yeah.
I've never seen it really like.
I've seen it
Someone's
over 100.
not going to be 100 beats per minute, and then you're going to give them albuterol, and they're going to shoot up to 130.
Right.
It's going to be a pretty like very small noticeable increase, like maybe 105, maybe 110.
Yeah.
And it brings the question as to if someone's beating 140 times a minute when you give it, are you really worried about the heart rate? Would you be worried about it in this case? So it's kind of a component to be aware of, but the medication is going to do more good than harm in these cases.
Right. So yeah, I think that's everything with albuterol, the 2 receptor sites. Okay, 2 more of these and then we'll take a break. Acetaminophen. Drug name, is that the generic name or brand name? Generic name. So whenever you write a report, you're saying acetaminophen. It's an over-the-counter medication. We carry it on the ambulances. It is used to treat mild to moderate pain. The IV form that we carry, that's at the medic level. We have found that works phenomenally.
And A level.
Oh, that's right. Ace can do it now too. Forgot about that.
I'm here.
Because initially, initially our main form of treatment for pain was narcotics. So now the state has opened up to us. Now we can give Tylenol IV, we can give ketamine, ketorolac, all that stuff. And they've also opened it up for you guys. So acetaminophen is open up to you for the Vermont state protocols, not for National Registry. But I want to teach you this because once you get your license, you're going to have to know how to use it.
So you give somebody a horse tranquilizer?
Yeah.
Ketamine, yep.
Yep.
Works
It works
wonders for pain.
great.
Great for rain
Love that
concerts too,
drug.
man.
Yeah, and we have 2 concentrations of it. We use it for pain management and for sedation. So to either make you go night-night or control your pain.
Or both.
Yeah, well, we're not in the ketamine goes beyond the fun part.
Yeah.
Knocks you right out. Doesn't let you have any fun.
No. Yeah, you don't get the lucid
Dreams of
Lucid
Dragon's
dreams
Garden
and all that stuff,
refrigerators.
we're either on the very low end or we're the very high end. So anyways, acetaminophen, so you guys give it PO. You can give 325 up to 1,000 milligrams or 1 gram. The big thing about acetaminophen, it's hard on our liver. Okay? So you need to make sure that the patient has a functional liver. If they have a history of hepatitis, if they have a history of liver cirrhosis, chronic alcoholism, those are all contraindications to us giving acetaminophen.
Isn't it like the common one, like ibuprofen, they're saying you take too much of that, you can do harm to your liver as well, or is that something else?
Yeah, high concentrations will affect your liver. You're actually more at risk of developing a GI bleed from ibuprofen.
Kidneys.
Yeah,
Ibuprofen's
hard on the
Ibuprofen's kidneys, Tylenol is, or acetaminophen is liver.
Yeah. So that's the big thing. So always make sure you ask them, if they don't know any history of their liver, then typically it's fine. They know, yeah, I have a history of hepatitis or I have a history of chronic alcoholism. If they look jaundiced, like their skin color is that, you're not giving them acetaminophen because that's a sign of liver failure.
Their skin color is that. They have a lot of other problems.
Yeah.
That's a yellow I've never seen on the skin before.
It's almost like a neon. Cool.
How did that affect
I
it?
might have swallowed some radioactive material at that point.
Right.
That's like Simpson yellow.
Yeah, pretty much. So yeah, always ask for any previous history, looking for contraindications. The other thing is they cannot have taken acetaminophen in the past 4 hours. So if they've taken the medicine to try and alleviate pain within the past 4 hours, we're not giving them more. And the main purposes of acetaminophen is it just increases our pain threshold. So kind of what we talked about before. We have prostaglandins that stimulate swelling and inflammation that causes our nerve endings to trigger pain basically, and acetaminophen just increases that pain threshold.
What if they've only taken like 325 milligrams, so it's like 2.5 hours away, you can't give them anymore?
They can't have taken any acetaminophen. Number one, we can't verify that they've taken it. We can't verify how much they've taken it. We gotta go by what we know and what we see.
Okay. So even if they say, yeah, I took 325 an hour and a half, 2 hours ago, so we can't
Still
give them.
not gonna work.
So you're saying they can't have taken that medication in the past 4 hours or any medication in the past 4 hours?
Anything with acetaminophen.
Okay.
So anything with acetaminophen, yeah. They can't, you can't get acetaminophen to them. It's in the past 4 hours. All right, last one, then we'll take a break. Epinephrine. This is another drug. Is epinephrine the brand name or generic name?
Generic.
Generic name. So the brand name of Epi would be?
Adrenaline.
Adrenaline. So a lot of places you go to, they may tell you, I have my adrenaline. It's epinephrine. So epinephrine comes in two forms. For your guys' case, you can give it for one purpose, and that's for anaphylaxis. Okay? We're going to go into anaphylaxis pathophysiology a little later on, but just understand that epi comes in two concentrations, and you give the one concentration. So this is epinephrine 1 to 1,000. And that is basically the concentration of epi, the parts of epi per other solute. So, epi 1 to 1,000 is a higher concentration. The other form we give is epi 1 to 10,000, which is this one, aka cardiac epi. Yep, that's what we use for codes. So epi 1 to 10,000 is less concentrated than epi 1 to 1,000. Okay? So, you guys can give it in two ways. One is through, this is a trainer by the way. I'll go over this real quick. You can give it either through Ready Check Inject, which is this guy. This is what Vermont has allowed you to do. Or you can give it assisting them through their auto injector. So with auto injectors, number one, don't put your thumb over the tip. For the love of God, don't do that. It's a 16 gauge needle that comes shooting out of there. Put that through your thumb and you'll never do it again. I can promise you that. Okay? So, this is with it out. That's actually how far everything comes out. There's a needle tip that comes on the end of it. We're giving it lateral thigh. Okay? If you need to go, it'll shoot right through pants. Unless they're wearing Carhartts or whatever, it'll go through basically.
Which they probably are.
Sometimes. Okay?
That's what you have scissors for.
Right, exactly. Trauma shears, they look great. So anyways, this is a trainer for you. You can take a look at it. Most services have trainers that you can use. If you're assisting them, lateral thigh, inject, oops, and let it sit for at least 5 seconds. Okay? Yeah, it hurts, but it allows you to breathe. Let you guys pass this
By
one.
the way, if you ever try to show anybody how those works, make sure you do what you did and tell them it's a trainer. I was trying to show my mom because we have someone in the house that needs one.
Yeah.
So I was like, yeah, this is how it works. And I was like, just watch. And I put it in her leg and she freaked out. I was like, it's a trainer. I forgot to tell you, my bad.
Oh yeah, that'll make them nervous. So I mean, it's a big needle that comes out of there. It's an auto injector, so it literally forces all the medication in a matter of a second. It's really quick. But you just leave it there just for a moment to make sure everything's gone through. So epi, for the cases that we're using it, it's a bronchodilator. It has smooth muscle relaxation effects, so it helps in the presence of anaphylaxis to basically open up their airway, allow them to breathe. It's not going to reduce swelling. It's not going to change the reaction from continuing. That's all still going to happen. Epi basically buys you time. It buys you about 15 minutes, and then you'll have to give another dose. Because whatever allergen that they were exposed to, their body's having a reaction to it, and it's releasing histamine, it's causing swelling, it's causing rashes. That's where epi comes into play. Just buy your time until you can give Benadryl or any one of those. So, does every allergic reaction need epi?
Nope.
No. That's a big thing.
Only anaphylaxis.
Only the presence of anaphylaxis. Just because somebody's saying they're having an allergic reaction, they're going to be anxious, they're going to be freaked out, you're going to get
Just be
called.
like, oh, I'm having a little bit of sinus, my throat start
Right.
closing up and on, struggling to
Exactly.
breathe.
Unless there's any type of airway complication, you don't need to give epi. Okay? And you'll know. You'll see their neck swollen, their tongue swollen, their face is swollen. That's go time. That's your time to give epi. So you can get some Benadryl on board. That's the main thing of epi. Increases vasoconstriction and bronchodilation.
What if a child tells you he's allergic to peanuts, he just ate some peanuts, and he's got one, do I wait? Monitor.
Yeah, monitor.
Monitor.
You're looking for airway complications. So something that's ingested. Other things we're looking for is GI system, an upset GI system. If they're profusely vomiting, and like, even still, if you're not seeing airway swelling or anything like that, that still isn't an incidence that you're going to give epi. It's
Okay.
really just that focus of, am I seeing airway
Vitals
complications?
start to
Right.
change.
Until you can get Benadryl on board or some form of
Okay.
antihistamine. Let's take a quick 5-minute break, and then get the other stuff we're going to hit on. Oops. EMTs assisting with prescribed medications. So there are certain meds that you can assist patients with. They're prescribed it, but they just need assistance with taking it. So some examples of those. MDIs. This is an inhaler. Anybody with asthma, COPD may have one of these. It comes in a puffer form. So it contains albuterol, which is a bronchodilator. So in the presence of asthma, we're helping them with this drug. So basically you just want to make sure you press down as they're breathing in and make sure they hold it in for a minute. And remember, you can get 2 to 5 breaths. This is a prescribed medication. We're going to go into the 5 rights of giving a med. But this is what an inhaler looks like. So some prescribed medications that you'll assist patients with: inhalers, nitroglycerin, and epi. We've already talked about epi, so I won't talk about that one too much. Patients who have any history of anaphylaxis, they're prescribed epi. It comes in somewhere over here. So kids, it'll say on it Epi Junior, and for adults it'll just say epinephrine. So Epi Junior is the half concentration, because the dose for kids is 0.15 milligrams of epi, whereas adults are 0.3 milligrams. So you can assist them with theirs. If you aren't licensed for ready check inject or anything like that, especially during your psychomotor, you'll say, I'll assist the patient with their auto injector epinephrine. Okay. big thing you want to check with that, make sure it's actually their auto injector, make sure it's not somebody else's, make sure it's in date, it's not expired.
When you say assist, do you mean like literally have their hand on it and help them put it into the like type assist or like?
No,
Okay.
you can give it to them.
Okay.
Yep. The nitro, some people like to take their own nitro. If you're taking the pills out, putting it in their hand, they're putting it in, or you're assisting them by putting it under their tongue. That's the same thing. That's assisting them with it. So bronchodilators, we already talked about this quite a bit. Used in patients with asthma, emphysema, chronic bronchitis, so COPD. Enlarges the constricted breathing tubes. I don't know why they say that. It enlarges your bronchioles, okay? Side effects include increased heart rate, jitteriness. Those are common. Like Joe said, it doesn't jack your heart rate up to 170. It may bring you up to 100, 110. But that's really it. So the main component of that is just bronchodilation. Okay. Nitroglycerin. So this is another cardiac drug. Nitro works as a vasodilator. So patients experiencing chest pain, that chest pain may be coming from their heart, and that may be due to a heart attack or angina, so constricting of their coronary arteries. So this works to just basically open up those arteries to try and allow some blood flow through to their heart. It comes in two forms. For what you guys are going to give, it comes in a spray, and it also comes in this guy that I'll pass around. So these are sublingual tablets. Don't open them because none of you have gloves, but you can take a look at them. So nitroglycerin is 0.4 milligrams that you're giving. The sublingual route, that means they're lifting up their tongue and you're literally just placing it under their tongue and just let it dissolve. Side effects of that, a headache is common. Okay, that's a normal side effect. Pretty much every patient I've given nitro to has experienced some form of a headache. That's normal. And then the other thing we're looking at is their blood pressure. You really need to monitor their blood pressure. If somebody's got a low blood pressure to begin with, I'm not giving them nitro because their blood pressure will tank from the nitro, and a nitro-induced blood pressure bottoming out is really hard to bring back up. It's not easy. So before we're giving nitro, make sure you get a good set of vitals. Make sure you're giving it for the right reasons. Okay? Any questions on nitro? So, patients who have a prior history of chest pain or cardiac in origin chest pain, they are typically prescribed nitro. Like I said, it helps dilate the coronary arteries, so the arteries that supply our heart with blood. Contraindications, low blood pressure. Patients who have taken erectile dysfunction medications, so Viagra, Cialis, Levitra, anything similar with that, those actually work on your blood pressure as well. So if they've taken one of those and then you give them nitro, you will bottom out their blood pressure. So always ask them, have you taken Viagra, Cialis, that kind of stuff. And then side effects, headache, dropping of the blood pressure, that's all normal. Epi, we've already talked about Epi. These are common auto-injectors, Epi Junior or adult dose epinephrine. These you can assist the patients with administration. If you get your EMT license and you go through the Ready, Check, Inject. Basically, this is the state's way of making it easy for you. There's a little pamphlet on the inside. So literally there's a syringe, a 1 ml syringe, and 1 ml of Epi. So it's 1 milligram and 1 ml. Okay? What's our dose of Epi for patients?
0.3.
0.3. So we're giving them everything that's in here?
No.
Hell no. Okay, 0.3. So if you can give 0.3, and this is a total of 1 milligram and 1 ml, how many doses can we get out of this vial?
3.
3. Good job. Okay? So that gives you a total of 3 doses, just in that one vial. This is the pamphlet they give you to make sure you're doing it appropriately. It draws out everything for you. So you can just go step by step. How much you're drawing up, where you're giving it, your indications for it, all that stuff. Okay? So, and the main reason they do that These are $650 to $850. Okay, and this is what services used to have to buy. They would expire. You'd have to resupply yourself. Every ambulance with these, they're expensive. That epi that's going around is $2 a vial. Super cheap, cost effective. So that's why they switched to that. All right.
Drop
Drop
something.
something on the floor.
Yeah.
Thank you. Put this back together after. So that's epi. We're giving it in the presence of anaphylaxis. It doesn't need to be for every allergic reaction. If they just have hives, they're itchy, that kind of stuff, that doesn't indicate the use of epi. Just in the presence of anaphylaxis.
So, quick question.
Yep.
If somebody realizes they're having an allergic reaction, not a terribly severe one, but one that's causing them concern, and they go into a full-blown anxiety attack, that might mirror a lot of symptoms, and at that point, what is a good differentiation of symptoms so that you can
So that's a tricky judgment call. Because,
give epi when it's uncalled for?
right, so a lot of times patients have a history of, they have a history of bee stings, an allergic reaction to bee stings. And we get those phone calls of, hey, I just got stung by a bee. We get there, they're usually anxious as hell. Using your judgment. If they're talking to me in full sentences, they've got a good clear airway, even though they're anxious, that doesn't warrant me to give them epi. If I'm worried that they may develop full-blown anaphylaxis, or I'm seeing signs of it, the swelling around the airway and that type of stuff, yeah, absolutely give it.
Yeah, I guess I see anxiousness and anxiety attack as different. So I think anxiousness would be a bit easier to suss out than
Yeah, a full-blown
a
anxiety
full-blown
attack.
anxiety attack can
Yeah.
very well mirror
Yeah, oh, absolutely.
anaphylaxis.
And that's that judgment call for you. Really look at, am I seeing airway complications? If they're talking to me in full sentences and I don't hear any stridor or any wheezes or anything like that, or any swelling of the airway, work with them. You're not going to necessarily harm them by giving them epi. Their heart rate's going to go up, their blood pressure's going to go up. The side effects wear off within 15 minutes, it's pretty quick. It's really a judgment call though. You're not going to hurt them if you give them epi.
Okay.
You're better off to give them epi than not to give them epi. I'll put it that way.
Do you find that people that have their own auto injectors have a pretty good idea?
Usually,
Okay.
yeah. Unless they've... So I'll use one case. I went to an individual who had his own EpiPen, but he had a history of an allergic reaction, but not full-blown anaphylaxis. So his primary doc prescribed him an EpiPen just in the event. So he hasn't really experienced that anaphylaxis reaction before.
Okay.
In that one episode, he was full-blown anaphylaxis, left his EpiPen at home. So, yeah, if they haven't experienced it before, they may not really know what they're looking for.
But most don't have a sense.
Yeah, usually. So, and allergies, you can grow into an allergy, you can grow out of an allergy.
Is that because our cells regenerate every 7 years?
Yeah, kind of. It's just really your exposure. If you're continuously exposed to, an allergen or anything, your body can develop at some point an immune response to it. That's why we don't wear latex gloves anymore, because healthcare providers were actually developing an allergy to latex. So, good question. Any other questions on epi? So, force protection medications, atropine autoinjector, this isn't really National Registry. They just included this in here. Atropine autoinjector to treat responders in the event of an attack. There's really no case. They don't make atropine autoinjectors anymore. So atropine is used for organophosphate poisoning. That's really it. Also for calcium channel blocker overdoses and heart blocks, but there's really no instance that we don't carry it in Vermont. It's not something here. It's not something used in any other state, but they do throw that in there. General information about medications. So drug names, we've talked about drug names. Everybody clear on that? Okay. What you need to know when giving a medication. Its indications, its contraindications, its side effects, and its untoward effects. Anybody know what untoward effects are?
I mean, they're not great side effects. They're not great effects, but the drug itself is doing more good than harm,
Right.
so you just kind of deal with it.
Yeah, exactly. Every drug we give typically has a side effect. Oxygen, not so much. It can have side effects, but every other medication we give will have some form of side effect. Okay? And that, just like she said, risk versus benefit. Okay? So, form of the medication, understanding how it's supplied, how it comes. Compressed powders or tablets, liquids, gels, suspensions, fine powder, gases, and sublingual sprays. Okay? Most commonly, the med you guys will give will either be in a pill form, it can be in a liquid form that's nebulized into droplets, and then also some spray forms. But that's really it. Medication safety and clinical judgment. Administering or assisting with medications is a serious responsibility. So just because our protocol says we need to give this medication for this symptom, you're really giving a medication to have a specific effect. Okay? I'm not just going to give a drug because the textbook says I need to give a drug. I'm giving a drug because I'm looking for a specific outcome and effect. Okay? Because remember, each drug I give can have a side effect that I'm not looking for. Nitro is a perfect example of that. Textbook says I have to give nitro for a chest pain. My job is to figure out why are they having chest pain. Did they have some form of trauma? Do they have a dissecting aorta? Do they have a lung contusion? There's multiple things that can cause it. Okay, so really trying to figure out, is nitro indicated in this setting? Know your medication. Know what effects it plays. Know what side effects it plays. It's basically it with that. And then using your judgment. You know, is this the right time to use this medication? Am I using it for this purpose? And will this purpose have a better outcome if I don't give it? Okay. So medication authorization. We go by offline and we have online medical direction. What is offline medical direction?
Standard procedures that are authorized.
Our protocols, right? Our protocols are our offline medical direction. So we have specific guidelines for us that tell us when we can give a med and when we can't, basically. So we can give nitro in the presence of chest pain. I can't give nitro to somebody who's experiencing toe pain, right? That's an offline use. That's an inappropriate use. So using our standard orders, you do not have to speak to a physician if it's within our protocol. If you're using, you have a medication that's in your formulary, so it's within your scope, but you're looking to use it for a different reason, then you have to have online medical direction. You can still only give your specific dose. You can't go above your dose unless you've given 3 albuterols and your patient is still experiencing symptoms and you need to give more. My protocol allows me 3 albuterols. I need to call online medical direction to give more albuterol. Okay? When you're asking for online medical direction, you need to speak directly to the physician, listen to their order, and then repeat the order back to them. Okay? So that's that closed loop communication. Ask for clarification if necessary. Okay? So they tell you to, not all physicians know what's in our scope. Okay? So a physician may tell you, give this patient ondansetron. Well, you have to tell the physician, ondansetron's not in my scope, I can't give that drug. Is there anything else we can do? Or he's telling you to give a dose that's not within your scope. Clarify with them, that dose is not in my scope, I can't give them that amount. Okay? Like I said, physicians don't know all our protocols and all our doses, so you need to be clear with them. You're the expert on that.
Can they override that or no?
No. Because then you'd be going out of scope. So, they're usually nice about it.
No, I didn't,
They're
but I
shut
didn't know if that would, if like, they could override it and it would be riding under their license, or like, I didn't know if that was ever.
It is riding under theirs, but at the same time, it's riding on yours too. So that's kind of the big thing with that. That's a good question. So make sure you know your doses, make sure you know your protocols for your medications you're giving. The 5 rights. Number 1, right patient. Okay? especially if you're assisting somebody with a medication. Is that medication prescribed to that patient? Okay? Is it the right time to administer the medication? So am I using this medication for this purpose? Okay? With time, also, so there's typically 6 rights. They include this in there. Expiration dates also goes with time. Okay, so is the medication expired? We do not give expired medications. Okay, so if the medication is expired, we don't give it, and making sure we're giving it at the right time to the patient. Is it the right medication? Is it the right dose? And am I giving the medication by the route of administration? So are you giving it appropriately?
If the patient's medication or you're helping them administer is expired, you still don't give it?
Nope. Nope, then we don't give it. Good question. So these are always things you should double check yourself on, especially when you get to your first patient. You know, the first time you give a medication or whatever, you're going to triple check yourself 100 times, and then you can ask your partner, you know, I'm giving, let's say, Haldol. You know, I'm going to inject somebody with Haldol. I double check myself that it's Haldol, it's not expired. I'm giving it because they're having, usually it's, you know, it's for a patient who's delirious. And when I say delirious, they're having an excited delirium state. So they're super agitated, they're combative. Then I'll give them Haldol along with Versed or something like that. But I double check myself. I'm giving this amount, I'm giving it for this purpose, and it's within date. And I'm giving the right dose. Okay, so those are good post-test questions. Just make sure you know those. What would be the potential risk to the patient if each of the 5 rights were not checked prior to administration?
Wrong medication, old medication, wrong amount of medication.
Can it be detrimental to them?
Yeah, it could be deadly.
Absolutely. Yep. Or it may not have, if it's an expired med that's 10 years old, it may have 0 effect on them. Okay, so you're trying to achieve something, you've given a medication that's expired, and it does nothing for them. Right? We're not doing ourselves any favors, we're not doing the patient any favors. So that's why we always check ourselves on that. That is a post-test question, just a heads up. Routes of administration. So we can give oral, so PO, which is swallowed. Sublingual, which is dissolved under the tongue. 2 meds we carry for that is nitro and Zofran. Those are both dissolved under the tongue. The spray as well. If you guys carry spray, you have them lift up their tongue and you spray it under their tongue. The other form is inhalation, so breathed into their lungs, is aerosolized, and then from there, it affects their, if you're using albuterol, it affects their beta-2 receptor sites for bronchodilation. Intranasal, sprayed into their nostrils. Narcan, we use intranasal. And then intravenous is injected into a vein directly. Intramuscular, IM, injected directly into a muscle. Subcutaneous is the cutaneous tissue just above the muscle. Intraosseous, so into their bone marrow. So if we do an IO, if you guys go to the AEMT or paramedic scope, you can do IOs. And you can give drugs directly into their bone marrow. And then the last way is endotracheal. So if we have an ET2 established, that's more for infants that we'll do that for. We can administer the medications straight through the ET2.
What does PO stand for?
I'm out.
Yeah.
What's that?
Great
I know.
question.
Well, I know it's like mouth, but
Yeah.
what's the P? O is
I'm
probably.
not 100% on that. Yeah, O is oral. I'm not 100% what the P stands for. I'll find out though. So yeah, PO is oral, SL sublingual, IM intramuscular, IN intranasal. You guys get the idea. Okay, sorry about this, we do have to cover it. Pharmacodynamics and pharmacokinetics, okay? So, how a drug works on us, how our body works on a drug, okay? Your book talks a little bit about this, it's not very specific. I want to make sure you guys understand this, because when you're giving a medication, this is what's going on, okay? So pharmacodynamics is the study of effects of a medication on our body, okay? So the effects that we're looking for, whether it's side effects or specific effects, that that medication is playing on our body. What effect will the medication have? Will it cause vasodilation? Will it increase your heart rate? Pupillary constriction? You know, any one of those things. That's the drug playing effect on our body. How will this medication affect my patient specifically? So what specific effects are you looking for? I'm giving nitro to increase vasodilation, to increase perfusion to their heart. Side effect of that, they're going to drop their blood pressure because nitro is doing what it's supposed to do. Patient-specific factors change how medications work. So this is a good one. Age plays a role on how the medication works. Liver function plays a role. Kidney function. Pre-existing conditions. Okay? So a good example of that, if I give a patient, let's say a 40-year-old, fentanyl for pain management. If I give that 40-year-old 100 mics of fentanyl, their liver will metabolize it fairly quickly. They'll feel the effects fairly quickly. They may develop decreased respiratory drive, vasodilation, decreased heart rate. That usually happens pretty quick when I give the med. Let's take a 95-year-old. They don't metabolize it as fast. So I don't see the effects as quickly. You know, they're still saying 10 minutes later after the drug, I'm still feeling pain, I don't feel any effects. I go and give them more. Finally, they start to metabolize that drug, and all of a sudden, it hits them, and they go unresponsive. They go into respiratory failure. Those are all things that can affect a patient. So keep that in mind, especially with our older population. If I'm giving them nitro, and it's not working fast, and I go and give them another nitro, all of a sudden their blood pressure tanks. Okay? So keep that stuff in mind. Allow that drug to take effect. In some cases it may take more. So everybody's a little different. Pharmacokinetics. So this is basically how medications are metabolized and transferred through the body. So the main factors of pharmacokinetics are absorption, bioavailability, distribution, metabolism, and excretion. So how that drug is passed through our body. So absorption, you have enteral and perienteral. So enteral is absorbed through the stomach. Perienteral is absorbed elsewhere in the body. So IM, IV, subcutaneous, intranasal. So that is just specific to how the medication is absorbed through the body. Distribution. So medications travel into our bloodstream. They reach specific target sites, specific cells, and play an effect. So opioids target our opioid receptors. Albuterol targets our beta-2 receptors. Epinephrine targets our beta receptors and our alpha receptors. So it becomes distributed through the bloodstream into our target sites. Metabolism and bioavailability. Some medications are metabolized in our liver, in our kidneys, our lungs, our GI tract. When it's metabolized, we're looking for a therapeutic index or a therapeutic threshold. Okay, so part of that medication is metabolized and it may not play an effect or reach the target receptor sites. That's why drugs have dosages. Okay, they've done, when that drug was going through trials, they did FDA studies to reach the therapeutic threshold to achieve what that drug needs to do. So that's why we come up with dosages. Okay? So bioavailability is the amount of medication left over when the medication reaches the target receptor site. And that's how dosages are calculated to achieve a therapeutic index. Lastly, we have excretion. So rate of excretion is dependent on age, state of health, and also the specific medication. Amiodarone, if anybody's heard of amiodarone, it's a drug we use for cardiac arrhythmias. So somebody who's in VFib or VTAC, it works to basically get them out of that arrhythmia. The half-life of amiodarone is 45 days. So that drug lives in their system for 45 days. And when we give it, we get them to the hospital, they go on a tapering dose of amiodarone. So they're in the ICU, and they basically have to be on amiodarone for the next month. just from our one instance of giving that drug.
Wow.
So aspirin's a good example. Aspirin lives in our system for 7 days. So that's the half-life of aspirin. So the rate of excretion, again, is dependent on age, how quickly they metabolize the drug, how quickly they excrete it into our GI tract, into our urinary system, or exhale it through their lungs. Any questions with that? I went through pharmacokinetics kind of quickly. It's a lot more in-depth than that. Your book doesn't really go that in-depth with it.
Yeah.
But I just want to touch on that with you guys so you kind of understand the difference. All right, so we've given the drug. Now what? Reassess them. Are we getting the effects we're looking for? Are we getting side effects? Are we getting worsening effects? After administering the medication, you're going to reassess the patient. If you're giving a pain medication, seeing if their pain is relieved. If you're giving nitro, did their chest pain relief? You're also reevaluating their vitals. Did their blood pressure drop too much? Or is it at a solid level that you can give another dose of nitro? Reassessing your patient continuously after you give a drug. Making sure you're doing better for them or helping them out instead of not helping them at all. And then clearly document the medication you administered. So what drug you gave, how much you gave, and did it have any effect? Good effects or bad effects. You need to document both. So some common medications that you'll see in the field. Advair. Has anybody ever seen Advair or on Advair? So it's a medication for COPD. It's also used for some cases asthma. It's mainly focused on respiratory diseases. It should not be used for emergency treatment of an acute attack or breathing difficulty. So this is more of a long-term use medication. Our short-term, quick-acting use medication would be albuterol or Duoneb. So they threw this in here, some vitamins and herbal agents that patients take. This is what they're used for. Some common ones you might see. Garlic is used for high cholesterol. Ginger root for nausea, vomiting. I haven't really seen any of these other ones.
Some drugs work.
Yeah. And some of our drugs are actually derived from plants. So, just a good thing to see. Oops. All right. Assisting with IV therapy. So, you're on scene with an ALS provider, and you need to assist them with setting up a drip set. I'll go through that here with you guys. Sometimes you might need to set up a bag of fluid. So, setting up an IV fluid administration set. Ways fluids and medications may be administered into the vein. So, they use heparin. Heparin is a paramedic and a critical care paramedic level drug. They use that as an example. Heparin is diluted in saline. And it's given IV. So when we're giving an IV drug, we need to make sure that they have an IV placed, that it's patent, and it's not infiltrated. We need to clean the hub before we're giving the drug so we're not causing phlebitis or anything like that. And the lock contains a port for administering medications. So we screw our syringe to a specific lock, and then we can administer the drug. So traditional IV bags, there's multiple different forms of fluids that we administer. Where did that blue bag
It's
go?
over here.
Yeah, that's one of them. So that's D10. Common fluid that we give is normal saline. Salt water. And then this is the drips that we use to give the drip. So, when it comes to fluids, there's two forms of fluids that are within our scope of practice to give. You have normal saline, which is this, 0.9% sodium chloride, and the other is lactated ringers. So lactated ringers can be given at the AEMT scope and at the paramedic scope. And it's basically just situation dependent on which fluid you're going to give. 9 times out of 10, we're going to give normal saline. Does anybody know the difference, or what is so special about normal saline? If not, no worries. So normal saline is basically the same makeup, minus red blood cells, white blood cells, and platelets, that's within our blood. So salt concentration is the same. It's called an isotonic fluid. You have hypertonic, hypotonic, and isotonic. What that talks about is the concentration of solute to solvent. Okay? Anybody who's taken a chemistry class, you know what osmosis is. Anybody work in sap, making maple syrup? Okay, so maple syrup makers, they may have an RO, reverse osmosis. So that is basically, yep, and that just concentrates the sugar content when they're making sap. So that way they can make sap quicker when they're boiling it down. That's reverse osmosis. Regular osmosis is the motion or the
Absorption
movement.
of liquid through a...
Yep, you got it. So it's the movement of water from a lower concentration to a higher concentration. Okay? So you have a semi-permeable membrane. Those dots are solvents, or solutes, I'm sorry. It's just sitting in a little bit of water. Okay, so we have a low concentration of solute and a high concentration of solvent. Water is going to want to move from this lower concentration to this higher concentration, okay, to make it equivalent. All right, so that way the concentrations are equal on both sides. So, coming back to fluid, we have electrolytes in our bloodstream. We have water, we have oxygen, we have carbon dioxide, we have all those things. So if you think about our cell, let's take our blood cell, for example. If I give a fluid that's got high concentrations of solute, the water within our blood cell is going to want to leave the blood cell and come to our extracellular space. Okay? Because I've got all this solvent, or solute, sitting on the outside and nothing on the inside. What's that going to do to our cell? Shrink it. Right? And the opposite, if I'm giving a hypotonic solution, so this would be hypertonic. If I'm giving a hypotonic solution, so there's not much solute on the outside, and there's a higher concentration of solute on the inside. Where's that water going to go? Inside the cell. What's that going to do to our cell? Make it bigger, right? So where saline comes in, saline has the same concentration of solute that's within inside our cell as outside. So it won't force water in, it won't force water out. That's why we give saline.
It's neutralized to the body, essentially.
Exactly. It's an isotonic fluid, and that's why we give it. It won't play that effect on our cells to move water in or move water out. There are certain situations where we want to give a hypertonic solution or a hypotonic solution.
Dehydration?
It's actually more with TBIs and burns. Those are two big things that we play that role in affecting that. We'll talk about that more when we get into trauma. But just to give you guys an idea, that's why we give saline. Okay?
But the other ones you give ringers.
So ringers.
That's what thought you were going to do.
Nope.
Yeah.
So what's special about ringers? Ringers contains 3 extra electrolytes than a bag of fluid does. So a normal saline fluid contains, can you guys see that over there? I'm sorry if you can't. Sodium chloride. Sodium chloride is a salt. Okay? Sodium and chlorine both play a major effect on our cardiac cell cycle. Triggers our cardiac cells to stimulate, create a heartbeat. So those are okay to give and won't play too much of a detrimental effect on our body. It'll help increase our blood pressure, increase our blood volume. Lactated ringers contain potassium. And bicarbonate. It contains lactate that's broken down by the liver into bicarbonate. Okay? So, you can read on there, what's the pH of normal saline?
Fairly neutral. Where is it?
What did I do?
5.6.
5.6?
Yeah.
What we got? 7.2 is normal.
So normal saline's pH. It's 5.6. Is that acidic, basic? Acidic. Anybody know
7.2.
acidosis, alkalosis?
We're on 7.
Acidosis is below 7.25.
Close. So normal blood pH is 7.35 to 7.45. That is normal blood pH. That's pretty low, right?
Yeah.
If we're giving somebody basically an acid and they're already in an acidotic state, that's not going to help things, right? Lactated ringers pH, so LR, is 6.9. Still an acid, but less of an acid. Okay? So those are instances where we would use LR instead. And that comes into patients who are in metabolic acidosis, or commonly burn patients, trauma patients will use LR. Okay? Mainly because of these extra electrolytes.
Dehydration.
Yep. Yep, exactly.
You can't do a quick test in the field to find out what their pH in their blood is, so you have to go by what you're seeing,
I go by signs and symptoms. Okay. So when we get into pathophysiology and even a little bit in A&P, we're going to go over acid-base balance for the body. So I won't get too much into that tonight. That's kind of my favorite subject. But understanding these terms, what's normal blood pH, and then what medications or fluids we're giving that can affect that pH. Does that make sense with everybody? So, that's what our fluids are. Now, how we're setting them up. You guys want me to go through how to set these up, or do you guys know pretty well how to set them up? I'll do it real quick. I'll do this in 10 seconds. So, basically, these are all sterile. You open them up, they have a little slit tab to open them up. Normally, I don't know if every ambulance does, but normally we want to give warm fluids. So fluids sitting on a warmer, they're usually in a range of 101 to 104 degrees. I would rather give somebody warm fluids than cold fluids, especially when we get into trauma. We'll talk about that, how hypothermia can affect the coagulation and all that stuff. Anyways, so this is our normal bag of fluids. I'm going to steal you for a second. So you have a little top that you're going to pull here. That comes out, fluid's just not going to start running down. That whole perfect intuition.
Get lucky every once in a while.
Okay. Now this is our administration set. Okay. So the special thing about these sets, the ones we're carrying here, they have a little blue tab here. Not all sets have this blue tab. That's actually a vent. Okay? So we don't need to use it for this. However, glass bottle medications, we have to use this. Because as we run fluid out of here, the bag will collapse. Okay? And medication will still run. In a glass bottle, it will not collapse. The medication won't run. So that's why we have that. So you basically unravel it. You have your port here that you're going to inject directly into that bottom site. I'll show this real quick. You also have a medication port here, so we can screw a syringe directly to this and administer whatever drug we want to give. This one doesn't have it. The old school ones, before they came out with these lure lock tips, it was actually you had to have a needle and use that needle to directly inject into your site here. do that in an ambulance at 70 miles an hour down the road on Route 7. Yeah, that's why we did away with those. And these are all needleless. Okay? So you take this is your rate chamber. So this is what I use to titrate my drip rate, how fast it's running in. And then this is also a clip. It's open now. If I slide it, it will close and prevent any drops from going through. Okay? So I open this up. When I started out, I close it all the way. Thank you. So you inject it in until you're up to the hub there, and then fill your chamber. So you squeeze the chamber, and it'll start to flow in. I go about halfway. I don't want it full all the way because I want to be able to see my drip rate. Okay? Okay. So then from there, I've still got air in my line, right? I don't want to inject that air into somebody's vein because now you're going to cause microemboli and air embolisms. So we want to make sure you run that air out. Now I start to see drops coming out. I know I've got the air out. Okay? And then from there, clean the patient's IV site, and then you can screw this directly to their IV hub and run the medication in. Okay? Always double check yourself on this. Sometimes we get complacent and we forget. Whether it's your AEMT or paramedic partner doing it or you're setting it up, just check and make sure that you've run the air out of the line. Okay? Any questions about that? Pretty straightforward. Yeah.
So when it says assistant setting up, we're basically helping with that part, but
Yeah.
when it comes back to attaching it to the IV hub, we can't do
Yeah,
that.
yeah, your AEMT partner will do that, or your paramedic partner.
You have several different IV type bags with, like this one here had something in it.
Oh, this one?
Yeah. So you're carrying that in the ambulance. You've got these marked. You're not telling the EMT, where it is, or he just needs to know.
Yeah, so that's
Yeah.
working with your partner.
Yeah.
You know, so if I'm working with my AEMT partner, through orientation and rig checks, you'll know where everything is. So when I say, hey, I need a bag of fluid, I need normal saline, they'll grab a bag of saline, set it up. Before I give it to that patient, I'm double checking whether I'm setting it up or they're setting up that it's the right fluid that I'm looking for.
So the two of you are taking responsibility of what's going to go in there. Okay.
Yep, exactly.
Yeah.
So this is dextrose 10%. That's normal saline. And then we also have dextrose 5%. This is what we're using when we're doing certain medications. So a good example of that is if I'm using epi as a pressor, I'm using this, or norepinephrine. This is what we're using. And that just basically has to do with the metabolism, metabolizing the dextrose, leaving behind the
That was
drug.
putting the injection into the.
Yep, I'm injecting it directly into this and then running it through. Okay? That's pretty much those. And same thing, we're using the same administration set, hooking it up, running the medication through, making sure we're getting all the air out. So exact same thing with that. So a traditional IV bag, hang it above the patient. If I hang it below the patient, they're gravity fed, it's not going to do anything, right? If I'm looking to run a lot of fluid volume in a short amount of time, they make, basically it's a fluid compressor, so it's a little bag that goes around your bag of fluid, and you pump air into it, and it compresses hard against that bag of fluid to really run the fluid into that patient. If you don't have that, a blood pressure cuff works. Wrap a blood pressure cuff around that and pump it up, and you will see you won't have drops, you'll have a stream of fluid going into the patient.
Why would you want to force that?
So cardiac arrest is a good example. Treatment of hypovolemia. So if I'm seeing blood pressures in the 60s, systolic, then I'm going to do a mass fluid infusion to try and get that blood pressure back up. So yeah, that'd be the main reasons. Constantly flows fluids and medications into patients, so making sure your drops are going in. Not every patient requires fluid. Sometimes you'll have, if their blood pressure is really high and your fluid's not being running, you'll actually see blood back up into the fluid chamber. Don't freak out about that. It can happen, but just something to watch for. So clear plastic tubing connecting fluid bag to needle or catheter. We went over that. 3 major parts: the drip chamber, which is this guy. Then you have the flow regulator, which is this guy. This just regulates how quickly the fluids are going to run in. We count our drops.
So basically just pinch the line?
Yep, exactly. It's just a little wheel that will pinch the line down to a specific amount.
And that's how you're going, is by the drips?
Yep.
Counting drips?
Drops per second.
Okay.
So I won't go too much into it. Each drip set has basically a volume and a drip rate. So this is a 10 drop set. They make 10 drop, 20 drop, 60 drop sets. And basically what that means for every 10 drops is 1 ml of fluid. Okay? So if you're trying to figure out your drip rate, I want to give 250 mLs in an hour. Then I calculate out, okay, I have 10 drops per ml. How many drops do I want per minute? Basically. Okay. Fun stuff to figure it out on the fly.
Yeah.
So the lower the number, the more fluid that's going in.
Correct. So this is so this is a 10 drop set. So for every 10 drops is 1 ml. For a 60 drop set, 60 drops is 1 ml. Okay? So it's basically the size of
The droplets that are coming through.
correct.
So the lower the
This
number.
chamber here.
Yeah, the lower the number, the more fluid that's going through.
Yep, exactly. And where we would want that is for specific medications that have to be at a really specific rate, and kids. Kids is the other thing. Okay? But in most cases, we'll just use a 10 drop set. And then lastly, the drug or needle port. So that little port that I showed you, there's needle and needleless. Pretty much every service is using needleless at this point. Extension set makes it easier to carry or disrobe patient without pulling out the IV. So it just makes it easier if they're moving their arms around. You're not going to pull the IV out or anything. Inspect the IV bag to be sure it contains the solution that was ordered. It is clear, it does not leak, and it is not expired. If you see like large crystals inside of it or something, we're not going to give that. Removing from your chamber, injecting into the bag, and then filling your chamber and running the air out. Return flow regulator. Troubleshooting flow problems. Constricting bands left in place by mistake. So if I start an IV and I left my tourniquet in place, obviously fluid's not going to run through because I've constricted the veins down. Nothing's going to run. So check to make sure that your tourniquet wasn't left on. Flow regulator wasn't left closed. All clamps are open. No tubing is kinked. No tubing caught under the patient. That's common. And then adjusting the flow rate properly. Monitoring the IV site for infiltration. Anybody know what infiltration is?
Not going into the
vein. So common symptoms of that, you just see a large bolus or swelling around that site. That's usually whatever you're giving, going to that specific site and not into the vein. That's it. Any of you guys want to go through chapter review? Okay. We can skip chapter review. So, a lot of materials tonight. Sorry I had to talk at you guys so much on this. Pharmacology is important. It's kind of our job. So your chapter post-test is due the 14th, and I believe that's also with Monday's lecture as well. That's all due the 14th. We'll be over. 8:30, I did good.